Hello, I'm Manoj Karmakar. Welcome to ISSPS TV. If you're enjoying our videos, do remember to subscribe so that you can get regular notifications of any future uploads. In this next live demonstration, I'm going to be demonstrating to you how you can perform a sequential ultrasound imaging of the brachial plexus from the ventral rami to the peripheral nerves in the axilla. This will be a sequential ultrasound imaging technique and will allow you to identify the individual elements of the brachial plexus. In this short demonstration, I'm going to do the sequential ultrasound imaging technique. We will try to put this into practice as to how you can identify the individual elements of the brachial plexus. We will then also use the sequence I showed you to perform a scan for the costoclavicular area and the medial infraclavicular fossa. If time permits, we will go into the axilla, but otherwise I think axilla most people are quite familiar with, so we will restrict ourselves maybe to the above the neck supraclavicular fossa and maybe the medial infraclavicular fossa. For this demonstration, we are going to be using the ViewSonic Labat machine. You can see here. This is their card-based system. We're going to use a high-frequency linear transducer. This is from 15 to 4 megahertz. We're going to optimize it. So I'd like you to, for those of you who are maybe newcomers or novices and you want to know what makes up a good picture, just try and focus on what I'm trying to achieve here. Daniel here is from ViewSonic. He is going to help us with optimizing the system. But since we are live, so you should be able to hear what I'm asking Daniel to, because it's a little bit further away. So we're going to find myself nicely comfortable here. So this is okay. So for this demonstration, the orientation marker, which is the red area over there to the top of the image, is going to be the top left of the ultrasound image. No, you need to the pointer. The top left of the image is going to be the lateral, and to the right is going to be medial. Okay, can I have some gel here, please? So we're going to use the gel. Now this is optimized for 15 to 4 megahertz, high frequency linear transducer. So can you increase the depth, the touch for me, please, Daniel? Okay, that's fine. Okay, first I'm going to optimize the image for the supraclavicular fossa. I'm looking for the subclavian artery. You can see the subclavian artery lying on top of the first rib, very close to the pleural surface. You can see there. Can you reduce the depth now? Okay. Is it possible to zoom a little bit? Maybe you can pinch it. Yeah. That's it. There we go. Okay. Now, what's the map? Can you change the map here a little bit? Frame map. Change it a little. Okay, that looks all right. Oh, okay. Right. Okay. Right. So this is I think I'm quite satisfied with this. And you can see here, we're going to look for the subclavian artery, and there are the elements of the brachial plexus that are located posterior and lateral to it here. Yes. Okay, so I'm going to now sweep the transducer in a cranial direction, like so. And then once we get to C5, I'm going to sweep it back again. Okay, and I will show you all the elements that we come across along the way. So that's the first rib that you can see the arrow there. Okay, now I'm going to go cranially and look for the C7 posterior tubercle. There we go. it just now appears in the ultrasound image here. You can see the C7 transverse process, the posterior tubercle. Anterior to that is the ventral ramus of C7. You can see the C6 on top of that. Yeah, you can see the C6 has actually two components to it here. Yeah, and this is the C6 ventral ramus. So you can see the C6 got to anterior and a posterior tubercle, and the C6 ventral ramus just emerges from it. Okay, you can see a big intramuscular bridge between the C6 and C7 ventral ramus. You can see the ventral ramus here. That is the big muscular bridge. Okay, and then if we go further up from C6, you can see the much smaller C5 ventral ramus here. Yeah, this is the much smaller C5 ventral ramus. Okay, since we are looking at the brachial plexus, let's now look in a reverse direction. We're going to scan distally. You can see the C5 over there. Focus on one element at a time. You can see the C6 is just now appearing. Okay, the C5 and C6 are going to fuse together to form a large superior trunk there. And then, as I mentioned, the neural stack is now visible here. You can see the superior trunk, the middle trunk here, which is the C7 now continues as the middle trunk, and the C8 ventral ramus is located on top of the T1 transverse process and first rib complex. Okay, so that is your the neural stack. Okay, so let me just put it on number 4. Number 4, F4. Better? So you can see here, that's the neural stack that we are referring to. Now let's focus on the superior trunk, okay? Now look at the superior trunk. It's quite superficial, less than a centimeter from the skin. And then you can see it's between the scalenus anterior, which is to your right, and the scalenus medius muscle, which is to your left. And now let's look at the superior trunk. You can see the superior trunk. If I go slightly caudate, I'm sliding it slightly caudate, you can see it is now dividing. You can see the suprascapular nerve has just emerged from it. Okay, that's the suprascapular nerve. Oh, this looks like a familiar picture from my presentation, right? Okay, so you can see here, they have a trifurcated. You can suprascapular nerve, the posterior division, and the anterior division of the superior trunk. So this is indeed the spar of the brachial plexus that you can see here in this individual, in this volunteer here. I go back again. You can see the C5 and C6. C5, C6 fuse to form the superior trunk. Superior trunk is now trifurcating into the S, P, and A, and then deep to the superior trunk. I already showed you the middle trunk and the C8. Now let's try and see if we can see the inferior trunk. So now we need to increase the depth a little bit. Okay, because we want to see where the T1. Okay, now if you see here, this is our neural stack of the 3 nerves, superior, middle, and inferior trunk. I'm going to sweep the transducer in a caudal direction, like so, okay, as you can see here, as it increased the angle till it almost coronal in some respect. So it's a coronal oblique scan in that respect. So I'm going to see you here, and then watch the C8. The T1 is going to come from underneath. There, you see the T1 has just appeared there, see? To your left. Yeah, there's the T1. Okay, I'm going to scan back and forth. This is going backwards towards the neural stack, going forward towards the supraclavicular fossa. You can now see the T1 has just emerged. There it is. This is the T1. It's going to go around. You can see the T1 very clearly now. It's going to go swing around the on top of the first rib to form the inferior trunk. Actually, you can see the C8 and T1 separate here, and they just form to form the inferior trunk here. So the inferior trunk is located over there. So now you can now see which is the suprascapular nerve. Look at the posterior and the anterior divisions of the suprascapular nerve. Okay, we are going to follow it down. You see the suprascapular nerve has gone laterally. Now, the two top elements are indeed the posterior and the anterior division. Okay, I already showed you where the inferior trunk is located, that one. So all that is left is the middle trunk here in the middle. This is the middle trunk, which is showing two elements, maybe just dividing into its posterior, which is where the arrow is, and the anterior will be more medial to it. So I think the bunch of grapes is actually all been unraveled if you do a proper scan from a distal to proximal. Okay, we start again. This is the supraclavicular fossa. You can see the subclavian artery with the bunch of grapes that we have already unraveled what they are. And I'm just going to scan, sweep upwards till we now see the posterior tubercle of the C7. That's the posterior tubercle of C7. If you put the Doppler there for me, please. Yeah, you can see here, move the box up a little bit. Yeah, okay, to your left. Don't want the jugular vein, want the smaller vessel. Okay, you can see the, yeah, you can see the vertebral artery and the vein, which are just adjacent to the C7 ventral ramus. Okay, that's the vertebral artery and the vein that are next to it. Okay, let's go B mode, please. Okay, now once we've seen the C7, I'm going to go backwards towards the C6. You can see the C6 with a prominent anterior and posterior tubercle, the C5. In fact, you can go even further, you will see the C4. This is the C4 here. So C4, this is your C5, then your C6 will appear, and that's the upper trunk being formed over there. That's your upper trunk, middle trunk, and C8 stack. So as I mentioned during my presentation, you can see here that the C8 is very consistently located on top of this T1 transverse process first rib complex. So you can see that once you see this C8, the structure that you see on top of that is the middle trunk, and the structure that you see on top of that is the superior trunk. So if you are doing selective trunk block, then this is our first target window where we are looking for the superior trunk, the middle trunk for our injection, where we deposit 7 mils close to the superior trunk in a periplexus location. Can you put the arrow there, please? To the left. Yeah, there. In this periplexus location for the superior trunk. And then you withdraw and redirect the needle towards the middle trunk, again within the interscaling groove. By now, the groove would already be distended, and you'll also see some spread of local to the C8. And then we come back, and now you can see how the T1 is coming out over there. That's the T1, and it swings across, fuse with the C8 to form the inferior trunk at the corner pocket. So now, if we were doing a SETV, then your this area would be already quite distended by the injections above, and therefore the aim should be only to deposit the local anesthetic adjacent to the inferior trunk. And I don't strictly go now straight for the corner pocket because it's distended. It's better to be more closer to the medial aspect of the artery than to the lateral aspect of the inferior trunk. Okay, so this is basically the scan here. Now let's see if we can see some of the major arteries that are located here in relation to the transverse cervical artery. There it is. It's very closely related to the superior trunk, as I mentioned. So if you put some Doppler there, you could see up. Okay, there you see here. This is one of the vessels here. This is the dorsal scapular artery. It's actually going from the subclavian, there you go, subclavian all the way through the neural elements, posterior part of the neural elements, and going away laterally. Okay, so this is your dorsal scapular artery. So sometimes, as I showed you in the anatomical variant, it could also take off a bit lower down at the costoclavicular space. So now if we go slightly more capillad, if we can see, you can see the transverse cervical artery over there in the middle of the scalenus anterior muscle, near the C6, the middle trunk. So need to align the patient. Is that on top of that? Yeah, yeah. So today I just can't show you where the transverse cervical artery is. But this is one artery that you need to find in your scanning routine before you perform this injection, because sometimes it's just where the arrow is. It's usually located on top of the scalenus anterior and the medius muscle. It could also bisect between the superior trunk and the middle trunk. Okay, so this is pretty much the upper part. It's quite simple. Start from the supraclavicular fossa and swing your way slowly upwards. It's a very simple, it's a very wristy action. So you just have to tilt your wrist upwards. Where is my, okay, so it is quite simple. You just have to use that sweeping motion. And if you use that sweeping motion, then you'll be able to identify most of these structures. From here, supraclavicular fossa, and then we bring away towards the C7 transverse process. Once you identify the posterior tubercle, it's easy. Then 7, you can see the C6 is bifid here. You can see the C6 is relatively large, and it's a bifid. So you can very easily mistake C5-6 as C5-6-7. Yeah, but it's actually C5-6-6. And then you can see the C5 is much smaller. It comes off through the C5 transverse process. 5 and 6 will fuse to form the superior trunk. So superior trunk blocks are a well-described technique now. It is used for shoulder surgery as a non-inferior analgesia, but more preservation of phrenic nerve function, as phrenic nerve sparing, not totally, but certainly less phrenic nerve involvement. And then you can now see the middle trunk and the superior C8 here. This is the neural stack. And then if you go further down, you can see the T1 is now just emerging from underneath, and it will fuse to form the inferior trunk. Also note the suprascapular nerve. Anterior suprascapular nerve block is the well-defined technique today. So find the superior trunk, find the superior trunk, and then you can see its trifurcation. And as it goes laterally, below the omohyoid muscle, that's the omohyoid on top of it, yeah. You can see the, that's the, sorry. You can track it. That's the suprascapular nerve. And then you'll see the serratus anterior muscle overlying the rib, okay? So here is where the long thoracic nerve is located, as Kevin showed us. You can see here. So the suprascapular nerve can be injected in this area. But remember that even an anterior suprascapular nerve block can affect your phrenic nerve, because it's not very far away from where the phrenic nerve is, although it is much farther away than the C5. But even an anterior suprascapular nerve block can affect the phrenic nerve in rare occasions. Okay, so this is about the upper part. So now I'm going to show you the costoclavicular space. Just keep it like this a little bit. Yeah, put your arm. Okay, now I'm going to do a scan of the medial infraclavicular fossa so that we can identify the relevant anatomy. So again, here the orientation marker is lateral. Okay, so you can see me. So this is lateral here. So this is going to be lateral. The image is going to be like so. So we'll start from the clavicle. We just put it on the clavicle. So you can see here, same structure. Then I'm just going to slide it underneath it. And here my aim is to try and get a good view of the subclavius muscle. I can see there now. You can see the subclavius. Okay, you can see the pec major and the subclavius muscle there. Yes. And you can increase the depth by 1 notch. Yeah. And you can see the the first part of the axillary artery is lying on top of the second rib. Okay, and the cords of the brachial plexus are clustered together lateral to it. You see there. Now, this is an angle at which I can now see the serratus anterior muscle very clearly. The anterior wall of the serratus one, anterior part of the serratus magnus here. You can see that when I can see the serratus anterior, the three cords are very clearly visualized. This is the lateral cord here, the medial cord just posterior to it, and then lateral to that is the posterior cord. Okay, so these are the three cords that are located there. A needle will come from a lateral to medial direction. And as I said, when you do a costoclavicular block, it is imperative to see the subclavius muscle. If you can see that the anatomy can be quite similar, slightly distally, which is the medial infraclavicular fossa. But now you can see here the cephalic vein comes in the way deep to the pectoralis major muscle and the deltoid. So you can see here, this is not the costoclavicular space, although they are quite contiguous in that respect. So always look for the subclavius, and the needle should be inserted from a lateral to medial. Although if you can't abduct the arm, as Dr. Salablanche and the group do, you may just put your arm here, please. Okay, we can just abduct the arm here. And now you see the anatomy has changed altogether. So it is not always easy to see the anatomy of the costoclavicular space with the arm abduct in the neutral position. See here? You can see that it's a little difficult to visualize them all. That's why I, for one, always prefer to keep the arm abducted at 90 degrees like so. But because we don't have a table, we just put the arm here. So here you can see, if I just start from the clavicle, I'm going to just slide it caudad. Okay. And now we can see can you reduce the overall gain a little bit? A bit too bright. You can see the pec major and the subclavius muscle. And then the cords of the brachial plexus are just lying lateral to it on top of the serratus anterior muscle. So with experience, you'll be able to define this much better. In some patients, it's much better seen than others. But important to remember that the aim is to hydrodissect your way into the center of the cluster. Once you understand the anatomical relations of the three cords, it becomes easier. And therefore, one, if you wish, if you're a beginner, I would suggest you use the nerve stimulator, because then you'll be able to define the individual cords. With the anatomical knowledge we have today, I don't think that is absolutely necessary. But if you want to develop your skills, then I think starting off with some nerve stimulation, and then as you get more confident in identifying these elements, then you probably don't need to do it on a daily basis. Okay, so if I go slightly more caudad, say the arm is abducted here, you can now see the cephalic vein. It's lying on top of the axillary artery here. Yeah, the axillary artery, a cephalic vein, axillary artery. And lateral to that are the three cords of the brachial plexus. You can see here. Yeah, the lateral is always superficial. Yes, the medial is deeper, and the posterior is more lateral to that. Now let's see if I scan more distally. You can see here, this is almost coming towards the lateral sagittal infraclavicular fossa. Now let me go back again to this area, and then you see the three cords here. If I scan more distally, so this is like you're dynamically scanning it. If I just place the probe in this lateral sagittal fossa, I may not be able to identify the three cords very clearly at first glance. But if you know exactly what the three cords are, like from a more proximal location, now I know which is the posterior cord. I now know which is the lateral cord. So if I keep tracking it distally, keep it on top of the posterior cord, please, just to make it more lateral and caudal. Yeah. So you can see here that by the time we get to the lateral sagittal infraclavicular fossa, the posterior cord has come to about the 6 o'clock position, you know, over there, and the lateral cord is more laterally there, that area there, yeah, and then you can't really see the medial cord so clearly. But if you track the medial cord more medially, now we are going to put the marker on the medial cord, and we just focus on the medial cord. You can see I have seen it go across between the artery and the vein. See, you can see there it is now swinging across to go in between the artery and the vein. So there it is. Yes, that's the one. So it's lying between the artery and vein. So in this young man, it's usually 3 o'clock, 6 o'clock, 9 o'clock. So he has got the perfect anatomy. Okay, the locations of the three cords are in good position. Okay, good. Oh, increase the depth from here. Okay, so that's pretty much about the lateral sagittal infraclavicular fossa. So now I'm going to show you the sagittal anatomy. Now, if you understand that the cords of the brachial plexus are running like so from the neck, coming down the clavicle, and then into the axilla. So if you imagine this is the position of the neurovascular structures, and if you do a scan like so, relative to my finger, it is indeed an oblique scan to the neurovascular structures. Whereas if I pivot the caudal end of the probe, if I pivot the caudal end of the probe more medially, like so, that becomes now at right angle to the cords, okay, relative to the arm. So sometimes when you perform these scans, try to think about the neural axis and try to align the probe at right angle to the axis rather than to the sagittal axis of the patient, because if your beam is at right angle to the structure, you're more likely to see it at a better more clearly. So you may have to pivot the probe a little bit like I have done here to better visualize it. Okay, now let's see some of the other associated anatomy that we can see here. So now follow the axillary artery. We are seeing the cephalic vein. The clavicular head of the pectoralis major is on top. You don't see the pec minor, okay? So as I scan more distally, now the pec minor has just appeared here. See, yeah, the pec minor has appeared, okay? And then you can see some vessels in between the pec major and the pec minor. Can you put the Doppler? That's easier. Sensitivity, PRF. Yeah. So you can see that that's some of the pectoral branches of the thoracoacromial artery between the artery and between the pec major and the minor. They are more seeing like little, yeah, there. Okay. Now, if you just take the Doppler away, The next important structure that I think you should be able to identify in this axis is the thoracoacromial artery as it emerges from the axillary artery. Where is it? Really, I saw it come out, but it's interesting, some comical variation. Normally it comes out from 12 o'clock position, but you see here, coming out from about 6 o'clock position. Okay, so put the Doppler on again. So you can see here, the artery is now coming off the axillary artery in a slightly different location here. It's more posterior than its typical anterior location on top of the axillary artery. See there? This is on the posterior part, on top of the serratus anterior, and then I think it will swing across the vein before it punctures the, if it goes into the interpectoral plane. Now, this artery can be a very useful landmark when you're doing some other blocks like some of the pectoral nerve blocks, okay? Because all the pectoral plexus are actually formed at this juncture where the thoracoacromial artery emerges. And we will talk more about this in probably the last webinar when we talk about using regional anesthesia as a sole anesthetic for major breast cancer surgery. Okay, so this is it. Now let's do the sagittal scan. Now, when you do a sagittal scan, obviously the orientation marker is pointed towards the head, and to your right is caudal. Okay, so now I place it. So this end is the cranial end. You can see here, I've aligned the probe directly in line with the axillary artery here. You can see the subclavius muscle very clearly there. And there you go. Yeah. Okay. And then if you just align the probe a little, you should be able to see the, I see the artery here. You can see the cephalic vein on top of it. Yeah. This is the vein that's going from right to left. You can see it's compressible. Compressible there. Okay. Of a different velocity. Okay, no. Right. So then you have the pec minor. You can see the pec major there, and the pec minor is just here. Okay, you can see here the pec minor. And why this is the upper border of the pec minor? I can say that this is a rib number 3. See here? Because the upper border, the pec minor is attached between rib 3 and rib 5. So you can see if I follow the pec minor here, rib 3, rib 4, and then rib 5 will be the one that is over there. Okay, so you see how the pec minor is spread over rib 3, rib 4, and rib 5. So if you're looking for counting the ribs, this can also be a very useful surrogate marker, looking for the attachment of the pec minor. Now I'm going to go a little bit more lateral, because you've now seen the vein here. The vein is medial. This is the vein. So this is actually useful. Also, it's been described as a transpectoral axillary vein cannulation. So you can perform a central venous cannulation at this level in some individuals where you can't place it in the neck or in the femoral area. This can become good, but be warned that the angle at which the needle enters the vein can be quite steep. So sometimes passing a guide wire is quite challenging. More importantly, the vein tends to get collapsed as soon as your needle touches the vein. So puncturing it, and you can see the pleura is not far away from the posterior wall. So this is never a first sight, but you can see that it can be useful. Okay, so if I go lateral now, you can see the artery, okay? And you can see the cephalic vein is right on top of it. The subclavius muscle is much better visualized. Between the subclavius muscle and the upper border of the pec minor is the clavipectoral fascia, okay? This is another fascial layer that you need to be familiar with. The cephalic vein is actually superficial to the clavipectoral fascia. And if we go a little bit more lateral, Right. So if we now go, here we go. Now this is it. And if I just go a little bit lateral, you can see the long axis of all the chords of the brachial plexus there, see? Now, as I mentioned before, there are two chords, one on top of each other, which are just juxtaposition to the artery. So this is the lateral chord where the arrow is. The medial chord is just posterior to that. Okay, if I go further lateral, you'll be only left with the posterior chord. So the posterior chord should be the one here. I think this is the posterior chord, which is now appearing hypo to anechoic here. This is the posterior chord. Then the two other chords are, here we go, here. These are the two chords. This is the lateral chord, and the one deep to that is the medial chord. Now, of course, you're not going to be doing your brachial plexus like block like this, but I hope I can show you the Phrygian cap that I was talking about. So easy, son. Here we go. You can see here, the chords of the brachial plexus are arranged. Go a little bit more left. Here. So the lateral chord is the one right on top of the arrow there. Lateral chord. The posterior chord is posterior to that. Yeah, that's one. And the medial chord is just behind it there. So you can see the three chords are arranged in a, here we go. You can see lateral, that's the posterior, and the medial is just below that. No, to the right. Yeah, that's the medial chord over there. Yeah, that's the medial. Okay, so there are different ways. I think this is something you may keep in your armamentarium someday when you are unable to form a block. This can be a good window because this is the window that Kilka used to perform his Kilka blocks. So you can always advance the needle from a podocranial outer plane some way, as long as you can get it to that deep to the pec subclavius muscle, then you can produce a block which would be a medial infraclavicular brachial plexus block. Okay, so I think this is pretty much what I wanted to demonstrate to you, really, with respect to what we have discussed today. Okay, Roshini, are there any questions? Come closer.
Dr. Semmer is asking if you can do a demonstration on intercostal brachial nerve block.
Intercostal brachial nerve block. I can try. Okay. Give me the probe, please. Oh, you have to switch back. Okay. I think for the person who asked this question, it's important to remember that the intercostal brachial nerve that we often look for is in the axillary area. And as the group from Barcelona has, with Dr. Salis, Xavier Salablanche and them have demonstrated, you need to identify the conjoined tendon, because the intercostal brachial nerve lives on top of the conjoined tendon with one of the medial cutaneous branches of the nerve. So if we now scan the axilla like so, and as you are familiar with, when you look for the conjoined tendon, it's there we go. You can see the conjoined tendon. Okay. Okay. And then we are going to go look more medially here. So once you find the conjoined tendon, we look more medially, and now you can see the pulsations of the axillary artery are quite lateral here. Now the plane of imaging is where the arrow is. Bring it down to the little bit down and to the right. Okay. So it is in this plane that the nerve is located. So if you want to do when we want to do an intercostal brachial nerve in this area, we usually sorry, my fault here. We usually identify the artery, the conjoined tendon, and then move it more lateral medially, the probe, and then try to find this plane on top of this latissimus dorsi and the conjoined tendon till you can deposit the local anesthetic in this plane. So we usually put the needle in this plane and inject the local anesthetic. In some individuals, after the injection, you can see some hypoechoic structures, or in some persons, you can also see them as they are. You scan them proximally and distally in a dynamic way. But they are small nerves, so not always very clearly visualized. Is this the highest resolution we are using, or put it on resolution? At least 15 megahertz we can try. Reduce the depth. Reduce the depth, please. Okay, so let's see the tendon very clear. But as you see here, not very easy to define the nerve. But in clinical practice, if you deposit a local anesthetic in that plane superficial to that muscle and tendon, then you will usually take out this intercostal brachial nerve in most of these cases. So I would usually do it like so. Now, normally when you do an axillary block, this is the window that you are using. When you are, especially if you're looking for the posterior cord, the radial nerve, then you have to look for this where it enters distally and it leaves the nerves here. There you go. It's going into the radial groove. So just do it above that so that you don't miss the radial nerve. And then here you can look for this plane, which is on top of the conjoint tendon, but at the same time, it is deep to the subcutaneous tissue and deep fascia. And so the needle can come quite close from here. You can see here, almost is subcutaneously really, and deposit, hydrodissect with saline and deposit the local anesthetic. 8 to 10 mils. You need a little bit of volume there, unless you can really see the nerve. But I usually use it as a volume block here. Okay, so hope that answers your question.
Okay. Dr. Smith, I would want to know if you can trace the supraclavicular nerve as well. Which
the supraclavicular nerves are, in my view, difficult to define. If you're looking at the supraclavicular nerves just below the clavicle, it's often not really definable. You can see here, if you just look, subcutaneous nerves. So even if you are looking to block them, I think trying to do it with ultrasound guidance, in my opinion, is trying to find the sky in the wrong places. Okay, so if you even go slightly above in the subcutaneous plane, it doesn't really show up very easily, even with high resolution, with a high frequency transducer, 15, 17 megahertz, you rarely will see it that clearly. So my advice is, when we do it for breast surgery, in some of the cases where they have a larger upper flap, then you need to take out the middle and the medial branches of the supraclavicular nerves. And just a subcutaneous injection along the inferior border of the clavicle is usually adequate in most cases. If you're doing it for shoulder surgery, then you want to block the lateral one, that lateral branch. I hope that answers your question.
Thank you. From the chat box, Dr. Lee from Melbourne, asking a question for the costoclavicular block. Dr. Lee finds there's difficulty visualizing the needle in plane when there's a probe tilt in the costoclavicular block. So asking any tip for troubleshooting?
Yeah, I think it is. That's a very good question, Dr. Lee. You're up till quite late, so I'm going to give you a tip here. Now, when you look at the requirement of the tilt, a normal tendency. Do you have a pen or a pencil? Yeah. The normal tendency is to follow the plane of the skin. Okay, so you usually, because you're looking like so, and the needle will go like so. So it is a common mismatch that usually happens, and this can lead to partial or no visualization of the needle. My suggestion is, When you tilt it, place it closer to the proximal end of the probe. You see here, use the proximal end of the footprint as the way you want to insert your needle rather than at the center where you normally want. So if you place it closer to the upper end of the probe, then you will more likely you will enter the plane very quickly. And if you do not visualize the needle, don't try and withdraw it and reinsert it. Find out where the needle is. I think common sense would say you should move rather than the needle, because this is going to cause pain to the patient. So once you do not see the needle, analyze where your needle is relative to the plane of imaging. If you find that the needle is too cephalad to your plane of imaging, then all you need to do is just withdraw and just redirect it a touch in the caudal direction, and vice versa. So these are two tips that you may find quite useful when you are performing a costoclavicular block. Try not to insert it close to the center of the probe. Insert it more closer to the upper end of the transducer. And two is, once you insert it, it is paramount to locate the tip. So move the probe, slide the probe up and down, and then find out where your probe is relative to the needle, and then readjust accordingly. Okay?
Okay, thank you. Dr. Mathakuma is asking what's the difference between a Kolkata block and a costoclavicular block. I'm also not very familiar with Kolkata block. I'm not sure if, Prof, you know anything about
No,
this.
I don't know what a Kolkata block is. Maybe it is from Calcutta. But Kilka block, not Kolkata block. Okay, I never heard of a Kolkata block from West Bengal. It is a Kilka block. Kilka block is a block that used to be done in the early 90s, where you did a proximal infraclavicular brachial plexus block by inserting a nerve stimulating needle. You identify the midpoint of the clavicle and insert the needle perpendicular to all planes. You insert it till you see the reflection of the elbow. Now, because as I showed you in the anatomy in this area, in the Phrygian cap, the lateral cord is the most superficial of them. So you will find the lateral cord response. But also at the same token with this Kilka, K-I-L-K-A block, it's a German anesthesiologist by name. If you just injected a local anesthetic based on just a flexion, musculocutaneous, or the biceps response, then your block is going to be very poor. So in those days, it was often recommended that once you get the lateral response, you advance the needle further till you get a medial response. So today we can say that in many of those cases, you actually went through the lateral cord, or on the side of the lateral cord, somehow you went and got the medial cord response, fraction of the finger, and so on and so forth. So that is the difference with it is a Kilka block is not ultrasound guided. It is usually nerve stimulator guided, and the motor response you're looking for is the lateral cord followed by the medial cord. And if you inject there, then you'll get a very good, dense, rapid onset of sensory motor blockade. With the costoclavicular brachial plexus block, we are doing ultrasound guided. We are coming from a lateral to medial direction. We are placing the needle at the center of the nerve cluster, and you're using a relatively small volume, 20-25 mils of local anesthetic to produce surgical anesthesia of the upper extremity, effective for surgery, maybe below the mid-arm to the hand. Okay, hope that answers your question.
Okay, we've got one last question from Dr. Eric Dufour from France, which is quite interesting. Can an intercostal block at the second rib during an infraclavicular block be spread to the intercostal brachial nerve?
That's a very good question, Eric. Wise men always think wisely. Yes, I think it is possible because the intercostal brachial nerve is not far away from that area. So it is with the same token, I always think that when you do an a costoclavicular brachial plexus block, because the costoclavicular space, if you go more lateral on top of the serratus anterior muscle, That's where these nerves are located, your long thoracic nerve. So I think the long thoracic nerve is probably one of the collateral damages of, I'm not saying collateral damage, it's a collateral block of a costoclavicular block. Now, nobody has really evaluated it, but I think it may happen that the long thoracic nerve is also affected. Now, if you look at the intercostobrachial nerve that comes out from T2, T2 nerve, if you look at the second rib where we are performing the block, so further laterally, the intercostobrachial nerve takes off and before it reaches the axilla. So I think a large volume of local anesthetic in that area may produce intercostobrachial nerve. Yeah, for to block that nerve. This is all I can say at this moment.
Okay, thank you. I think that's pretty much all the questions in the Q&A box.
Okay, thank you, everybody. I'd like to take this opportunity first to thank Rossini. I hope you learned as much as I did during this session. Thank you for putting it all together. Also, I'd like to take this opportunity to thank folks from Visonic, Candice, what's the other one? Vicky and Christopher, is it? They are being very active in marketing and supporting. So thank you for supporting us with your equipment and all your support. Daniel, for you coming out and helping us out during this live demonstration. And I thank you all for your confidence and in us and spending your Saturday and a weekend learning all these funny things that we do in the operating room. But at the end of the day, you've learned a few secrets. Don't give it away so easily because you spend the whole afternoon or morning, or in some cases, like somebody from South America said, it's 5 o'clock. So that was a good morning for you to have a warm cup of tea or coffee, put your feet up, and listen to us in your large television. But keep doing that. We have a few more, and we have a few more secrets, particularly the next one is how do I say this in a very simple way? Is a debate with a lot of emotion that's going to come up. So I would advise who are interested in the thoracic nerve blocks to be there because all of the high-powered people in this area will be there and they will be thrashing it out, say what is good, what is bad, and what is not so good. So with these few words, I would like to now sign out and see you again next Saturday in 2 weeks' time. Take care and bye-bye for now.
Thank you.